Hello, everybody, and welcome to the Orthopedics and Oncology Virtual Educational Conferences. My name is Cecilia Belzarena, and I'm an assistant professor at the University of Missouri in the United States. I specialize in pediatric orthopedics and oncology orthopedics. And today I'm going to be talking with you guys about osteosarcoma, its diagnosis, its treatment, and its research advances. So we should start by defining what's an osteosarcoma. There's some confusion there. When I usually ask residents or medical students, what is an osteosarcoma? They usually respond, oh, it's a tumor of the bone. Okay, what if I show you this image? I tell you, promise this is not connected to the bone. It's in the soft tissues. And you can see there, based on the images, that is a lesion that produces bone. And then if I later tell you, if you put the lesion on the left and the lesion on the right under the microscope, they look pretty much the same. So what does that mean? So basically, they're both osteosarcomas, because what defines an osteosarcoma is not its location, but how it looks on the microscope. So osteosarcoma, it's a lesion that produces a aggressive malignant osteoid matrix, which is usually characteristic of bones, but it can also be found in the soft tissues. That's why we have an entity called extraskeletal osteosarcoma. And again, like I said, when you put them under the microscope, they look exactly the same. They may or may not necessarily behave exactly the same. We're still investigating on that. But I want you to have the concept that an osteosarcoma is a lesion that is characterized by producing immature or malignant osteoid. I know in many books out there, it says primary bone tumor. It is, but that's not the complete definition. So how often they happen, who are the main patients that get osteosarcoma? So it's a very, very rare disease. In the United States, depending on the literature and the statistics, you will find that it's between 500 cases and 1,000 cases a year. It varies by countries. There are some particular world regions that are known to have more cases. We also don't know exactly why, but Africa and South America seems to be some of those. Here in the United States, we know those are our numbers. It's rare, yet it's very common in children and young adults, and we will see why. They tend to happen at the time where patients are having their rapid growth spurt. There is a hypothesis that the bone growing so much, there are many mutations that can be happening, and some of those cells can get in the pathway of going towards malignancy. But it can happen at any age. There have been cases of very, very young patients with osteosarcoma, as well as adult patients with osteosarcoma. That seems to be a different subgroup. It's usually what we call secondary osteosarcomas, mainly those related to Paget's disease or people who had radiation before or other conditions. But if we're talking classic osteosarcoma, primary type of osteosarcoma, you have to think between the ages of 10 and 30, basically. It seems to be also slightly more common in males, but the difference is not very significant. So in terms of etiology, what causes osteosarcomas? So the message here is the vast majority of osteosarcomas, it happens de novo. It's not associated with any genetic abnormality. It shouldn't necessarily run in families. But we do have a small subset of osteosarcomas that can be related to certain genetics abnormalities. For example, retinoblastoma, which is the picture you're seeing here, it's an abnormality of the eye. This is caused by a gene mutation on the RB1 gene, and this has also been associated with osteosarcoma. So those kids that present initially with this eye retinoblastoma later in life can develop osteosarcoma, so they should be watched for this. Then we have also p53 mutations, as any cancer, environmental factors, radiations, like I mentioned, and this applies mostly to the secondary osteosarcomas, and familial cancer syndromes. For example, I think the most common one is Li-Fraumeni, So if you see a patient that is young and is already developing the second cancer at a very young age, this is certainly something you need to investigate. This is detected by a genetic test as well. Also, patients that, you do their family tree and there's a lot of cancers in the family and they tend to be like at a younger age. Yes, you also should be looking for some familial syndromes. There are many. So here it's just like the most common examples, but you can also find it associated with Rodman-Thompson syndrome, Diamond-Black anemia, Bloom syndrome, Werner syndrome. But like I said, small subset of patients. Most osteosarcomas are related to genetic conditions or family syndromes. So how do these patients present? Well, there's one main factor is the location. Because, for example, if you have osteosarcoma around near your knee, which is one of the most common locations. So distal femur, proximal tibia, proximal humerus, very common locations. It hurts. Like if you have cancer in your lower extremity, that's an area where you're putting your weight, and it's gonna hurt because the tumor makes the bone weaker, and the growth of the tumor also causes pain. So patients usually tend to feel that sooner compared to tumors that are growing in the pelvis, for example. Pelvis, you have a big area for the tumor to grow. And what happens, unfortunately, is that patients with pelvic osteosarcoma can oftentimes be diagnosed later. Instead of getting an early diagnosis where the disease is localized, because they had an opportunity to grow for a longer period of time before causing any symptoms, it can be a problem for the patient. We'll see later on why. So most common symptoms. It's a kid that has knee pain, shoulder pain. That's like the early presentation of this. And what usually happens is, of course, not every time 14-year-old comes with knee pain, you're gonna think osteosarcoma. But I think the main thing is get an X-ray at least and warn the family, okay, this can be many things, but if the pain doesn't get better in the next few weeks, come back, get an X-ray. And if the X-ray doesn't show anything obvious, get advanced imaging. You have here on the slide other symptoms like fatigue, weight loss, fever, but those are more advanced symptoms. Those are symptoms that will present if the patient has had this cancer for a long time. So the usual presentation that you will see in an emergency department, in a peds clinic, in an ortho clinic, is the patient with pain. If that pain is also associated with a mass, like have no doubt, at least this patient cannot live without at least an X-ray. Okay. And then we have bone fractures as well. So there's about 10 to 15 patients with osteosarcoma that can suffer a fracture, and that's what we call a pathological fracture. Meaning the tumor took over the bone so much, and tumor is not as hard as bone, right? Bone is made to bear our weight. The tumor is not. So what happens is if you put your weight onto that tumor, it will fracture. And that's a pathological fracture. Surprisingly, most of these happen on the humerus, not the femur, but they can still happen. And there's a particular subtype of osteosarcoma that we'll see in the next slide that is more prone to having this kind of fractures because of the histology of this tumor. So what do we do? Okay, the patient came to us, bone pain, mass, we can feel it, it's there, it's not moving, it's painful. Sometimes there's some worms, some swelling. So the first thing that we gotta do, like I said, is get your X-ray. Okay, that can help you at least guide where the diagnosis of the patient is. Once that X-ray, you have it in and is abnormal, you need to get advanced imaging for two reasons. One, to see the tumor better, so we can see what it is, because up to that point, we can suspect an osteosarcoma, but we will know. So we need at least an MRI, and then we need other exams that are not to see the tumor, but to stage the tumor. And as you will see later, staging is a very important part of the prognosis of the patient. And then after you're done all that, then you do a biopsy. So don't put a needle just because you see something on an X-ray. You need to see the MRI. The MRI will show you where you want to biopsy. It will help you guide your definitive surgery. It will tell you what pathway you need to choose to get to the tumor and what parts of the tumor can have potentially more representative tissue for the biopsy and the diagnosis that the pathologist will make. So like I mentioned, we start with an x-ray. You have an x-ray that looks like this. You can see there's something weird there. I mean, this is not a normal bone. You can see that in this case, which is a classic osteosarcoma, you can see there's a lytic component. There's also an osteoblastic component, meaning the tumor is destroying bone, but also producing bone. You can see there's a little bit of a periosteal reaction there on the lateral aspect. So what you need to know is this is a concerning image. So that you cannot say, oh, go home with Tylenol. No. So that requires advanced imaging. And this, what you can see here on the right side is the MRI of the patients that we got. So the MRI, like I mentioned, can help us see the tumor better. For example, in that T1 sequence that you have in the center, you can see the extent of the tumor, and that will help you plan your surgery. And for example, on the axial image on the right side, which is with contrast, I can see how the tumor is extending outside the bone. That's why we were seeing some periosteal reaction on the x-ray, but you can see better here. You can see in detail. You can see, for example, the biceps tendon, unfortunately, is encased. So all of these things will help you with the diagnosis as well as planning surgery, as well as to see maybe you see any changes after chemotherapy. This shows some classic x-rays you will see in these patients. This is a very aggressive tumor you're seeing here. You can see within the bone, kind of that moth-eaten pattern. That should warn you. Moth-eaten pattern is either cancer or osteomyelitis. But most of the patients with a moth-eaten pattern on x-ray, you should see malignancy. Small percentage, maybe not, but that's what you should think, at least in the beginning. What you can see here, it's a classic pattern that you see in every textbook. It's called sunburns. So basically, this is the tumor that is expanding outside the bone, and it's causing the deposit of calcifications and ossifications in the Sharpie fibers. That's why you see that pattern that we call sunburns. The other very common thing that you can see is a Codman triangle. That's basically when the tumor that is inside the bone grows outside the bone and leaves the periosteum. Those are the classic images. They don't always look like this, and you have less frequent subtypes of osteosarcoma that will not necessarily look like this. So you have to be alert and have that in the back of your mind, especially in a growing kid, 10 to 12, 14, 16, that has a pain that's not going away. So we have our x-ray, our MRI. Like I mentioned, the next step is continue getting images, but now with the purpose of staging the disease, meaning we want to see how is the disease present in other body parts. So the most common locations for spread of osteosarcoma is the lung. So we're gonna get a chest CT scan. People often ask me with contrast, without contrast. In the case of osteosarcoma, when it spreads to the lung, what it causes are calcified nodules. So you don't need contrast for this. So it can be a chest CT scan without contrast. Second most common locations of spread is the bone. And for that case, in the past, we used to do bone scans a lot, but PET scans have taken over now. So you can get either. You can either get a chest CT with a bone scan or a chest CT and a PET scan. The other important thing that you can see here is what we call skip lesions, which are lesions that are in the main bone where the primary big lesion is, but separated in between with normal tissue. And that, even though it's in the same bone, acts in terms of prognosis and survival as a metastatic lesion. So keep an eye on this. You need to look at the entire bone, because you don't want to put these kids through surgery and just remove the main tumor and then leave a lesion that's like 5 centimeters above. So keep those things in mind. And then only after we got all that, then we're going to do a biopsy. There are many ways of doing a biopsy. You can do it with a needle. It can be you, can be a interventional radiologist, can be a core needle, or can be a mini open biopsy. If you're gonna go the route of the mini open biopsy, you must know that there are certain principles that you need to follow. So first of all, if you're not the person who's gonna take care of the surgery to remove the tumor, at least call this person and ask, like, where should I go? Because if you're gonna do a mini open biopsy, the biopsy tract should be in line with your approach for the definitive surgery, because ideally you should remove the biopsy tract with it. Now, if you're gonna do a core needle or a fine needle, the intervention radiologist can do it. They can look on images. They can see where the needle is. That's helpful. There have been some studies comparing the effectiveness in pathology. Core needles are good. Mini open biopsies are good. Usually the pathologist has enough to be able to diagnose this. So now we have our diagnosis of osteosarcoma, and with our images, we can see how far away is extending the tumor in its location. Is it going beyond the bone? Is it going to other compartments? Or is it in other body parts, most common being lung and other bones? So with that, we're gonna assign our patient a stage. The stage of diagnosis is a very important information to predict the prognosis of this patient, okay? The stage can change over time, but the initial stage will guide us in terms of prognosis and survival. So I mentioned earlier, there are different subtypes of osteosarcomas. Not all osteosarcomas are the same. They do not behave the same. Here you can see some pictures on the side. This is how different they look in the microscope. And by looking very different, they also behave very different. In general, the treatment is pretty much the same unless we're comparing high grade versus low grade. But like I said, they behave different, so they may have different prognosis, different risk of local recurrences, different risk of distant spread later in time. So that's just some information to keep in the back of your head, but mainly within the high grade group, they all gonna get the same treatment, low grade group, like also the same treatment, but you know that there are ones that can have more local recurrences, for example. So this is the most common classification that we have from the World Health Organization. The most common sarcoma is the one that you've been seeing here, the one that grows inside of the bone that we call central. Is usually high grade, but it has been described as low grade as well. So about 3 to 5% can be low grade, but most osteosarcomas that you're seeing that are growing within the medullary canal, seeing high grade. When we put those high grade medullary in the microscope, some of them may have, besides the osteomatrix we mentioned in the beginning, for example, a chondroid matrix as well. That should be high grade too. That will, for example, characterize a chondroblastic osteosarcoma. There's also another subtype that I wanted to mention, which is the telangiectatic one. That one I wanted to mention because one, the X-ray and the MRI can look slightly different. They have a much more lytic component than osteoblastic component. So you will see a much more destructive lesion, not necessarily so much sclerosis. And on the MRI, you can see fluid level. It can mimic an aneurysmal bone cyst. So be very careful with that. You should biopsy those. It's very hard to tell one from the other on MRI at times. And the other characteristic of these tumors is because they are so lytic, they can oftentimes have more pathological fractures. On the contrast, they are very good at responding to chemo. So very aggressive, more pathological fractures, but good response to chemo. In the past, when we used to have pathological fractures, that would automatically mean an indication for amputation. That's no longer the case. I mean, we know these tumors respond well to chemo. As long as you stabilize the bone, you wait for the patient to have the chemo, and then you can do a safe resection, and limb salvage is appropriate in those cases. So, these patients, there are gonna be several different specialties involved. So it's important to discuss these cases, for example, in a multidisciplinary tumor board. That may not be available everywhere, but at least discuss with the med-onc what's going to be the treatment of this patient and how a combine a plan. For example, I can tell you there are some countries, I have some friends, in South America, for example, that they have their tumor board via Zoom, and people from different parts of the world can join and help us and give us advice. So with this new area of communication, it's very easy to reach out to somebody and say, hey, can you give me a hand here? What should I do with this patient? Because this is a very complex disease, and it's good to have different expert opinions. So the treatment for disease most of the time is chemo, surgery, chemo. There are a few exceptions. Low-grade osteosarcomas, we don't need necessarily to do chemo. Tumors that you thought were low-grade initially, but then end up being intermediate, you can potentially add chemo after surgery. Adult patients that we know don't respond very well, there are some centers that will skip the pre-op chemo, because basically you're making the patient just wait for 3 months to get minimal necrosis. So some centers will go just straight to surgery and then discuss the possibility of chemo afterwards. Radiation has a very limited role with this tumor, mainly because it doesn't respond to radiation. So the role of radiation here will be mainly for those tumors that we cannot resect. Tumors that are unresectable, radiation can at least hold the growth for some time. But the main message here is chemosurgery chemo. Here are the most common used drugs: methotrexate, doxorubicin, and cisplatin. Those drugs have side effects. Those should be monitored by the medical oncologist. And usually they can affect the blood counts of the patient. So that's when they're done with their pre-op chemo, we have to run some lab tests and see if the patient is able to have surgery. You're gonna need at least 1,000 absolute neutrophils to do surgery. You have to make sure platelets have a good level as well. So we finish chemo, we're gonna run some labs, and then we'll proceed with surgery. Again, here we have a guideline of the treatment for these patients. Basically what we have been mentioning. So we're gonna start with the diagnosis, the chemo, and then we're gonna see if it's localized, and we're gonna take it out. Is it metastatic? Can we resect some of the metastatic lesions? Not all patients with metastatic disease are the same. A patient that has a single lesion or very few lesions, and those lesions are amenable of surgical resection, that should be the treatment. And some studies have shown that if you're able to resect those lesions, the prognosis is quite similar to those patients with localized disease. Very different story if a patient has multiple sites of metastatic disease. So the role of surgery here, like I said, we're gonna be involved in resecting the primary tumor and potentially the metastatic disease, depending on how many tumors are there, the location, the size, how well the patient is responding to chemo, and of course, if the patient can tolerate those procedures. Remember, most common locations of the lung, so that will possibly involve resecting parts of the lung. In terms of the primary tumor, the main decision we have to make is, can we save this patient's limb? And that means, can we resect the tumor with negative margins, meaning complete resection of the tumor, yet maintaining a good function of that limb? If we cannot fulfill those requirements, the patient will most likely be indicated for an amputation. Most cases these days, limb salvage. It's very, very rare for you to indicate an amputation, but that depends on many factors, how advanced is the disease, and oftentimes what possibilities do you have to treat those patients. The nice implants you can see here in the picture, they're not widespread all over the world. So there are other options, but we will discuss this now. So this is the most common form of reconstruction here in the United States. Basically what you're seeing here, it was a distal femur tumor that was resected, and that bone now is being replaced by metal. Because of availability of implants and usually the training people have here, This is the most popular reconstruction method here, but there are others. And of course, this is not perfect. Here you can see an article from 2012 that shows that they can be up to like a 24% total failure rate with these implants. The most common ones that are failing are the distal femur and the proximal tibia. The main mechanism to fail is because of infection. Well, these are big surgeries, big approach, long hours, and you're putting a lot of metal inside the patient that is also immunosuppressed from the chemo. So, blood infection. And the second way of failing is aseptic loosening. We have not perfected those implants yet. They are better than they used to be, but they're not perfect. Like what I tell my patients is, it's like you buying a car. Does your car last forever? No. So there's a chance that later on you may need some form of revision. And what we do with kids, because as you know, kids are growing, the bones are changing. If you put metal in there, that's not going to grow. So in kids, we have to think different options. One options are intercalary allografts. That means bones that are from cadaver, from the bone bank. Allografts, I really like this technique. It's very popular in Asian countries and also in South America now. You can use the same bone of the patient as long as the bone has certain features. You can sink it in liquid nitrogen 20 minutes and put it back on the patient, and that has minimal cost. We do have a few available expandable prostheses that look exactly like the one I show you, but they have the ability to extend the stem. That can work in kids. Another option is rotation plasty. That's usually for tumors in the distal femur. And a very, very young kid, you cannot put a prosthesis. One of the things of prosthesis is usually below 10 years of age, you cannot feed the stem. So you have to think other options. One is to do a rotation plasty, means you're going to resect the tumor and bring the tibia up and rotate it. So now the ankle of the patient will be its knee. I'll show you some pictures. It sounds complicated. And one more tool that we have is distraction osteogenesis. You usually do this through an Elizarov frame. You resect your tumor and then you cut some pieces of bone that you're going to transport slowly, and that's going to recreate the bone. That's usually good for diaphyseal lesions. So here is one example of those expandable prostheses I mentioned. So basically you put it in the kid, and then he comes to clinic, and that little machine that looks like a donut would lengthen the stem of the prosthesis. The main reason for this to fail is because the stem may not lengthen. But when they work, they're very good. And here's what I was telling you guys about a rotation plasty. You can see here, the patient has a distal femur tumor that was resected, and you can see the leg, the tibia now is connected to the femur, and the leg rotated. So the ankle acts as a knee. One thing that you have to be particularly careful here is that you have to anticipate the growth of this patient and figure out how to make the ankle, once the kid is done growing, be at the same level of the knee. And this can be particularly difficult. We recently had a conference where they presented a study trying to anticipate the growth of these kids, and it's very difficult. It's very difficult because chemo can make them grow slower. Also, you're having like a femur fracture, so we know that comes with some overgrowth. So it's very difficult to anticipate the final height of this patient, but we do know that some classic methods of calculating height overestimate growth for patients that undergo chemo. Here's the intraop procedure. It's complex. It's a complex procedure in the sense that, you know, it requires a lot of anatomy knowledge and dissection, but you don't need a lot of metal or expensive things. If with your dissection and a plate, you have your rotation plastic. And here is the recycle autograft technique. Basically what you do is you go, you dissect the location where the tumor is, you resect it out of the patient, you put it in liquid nitrogen, and that will kill the osteosarcoma cells. So now you have a bone that has no more alive osteosarcoma cells, and you can put it back in the patient so the patient can have its perfectly fitting self allograft. Again, very cheap. Nitrogen is very cheap, and what you need is just probably a plate or two to fixate that allograft back to the host bone. So, prognosis of this patient. So I usually ask people, okay, what's the prognosis of osteosarcoma? And people tell me like, okay, 5 years, 75, 80, but that's the right answer is a question is, okay, what stage is the patient? Because the stage will tell you the actual prognosis. That's the overall survival rate for these patients, but it's not the same thing a patient that has localized disease versus a patient that has a few lung mets versus a patient that has spread metastatic disease. So not all the same. Those things matter. Those will dictate the survival of these patients. This is just some message from the American Cancer Society, because people get, really anxious. They want to know how long, what are the chances of my kid, and then they get the number in their head. So, okay, so these are just numbers, their probability. Not every patient will necessarily fit the probability. Like it says here, numbers don't take everything into account. So, and factors that are not considered in prognosis, for example, like being a younger patient, being female. We don't know why, but females tend to respond better to chemo. Is it tumor in an arm or a leg or the spine or the pelvis? Can we resect this tumor? So patients will ask you for this number. It's okay to give it to them, but explain to them the caveat that that does not seal the fate of anybody. So you take it out, the patient went through his adjuvant chemo, and now you have to surveil those patients because disease can come back. There's a risk of local recurrence. There's this risk of distant spread afterwards. So you're gonna have to keep following these patients. It can be either you or the medical oncologist, but somebody should at least surveil this kid every 3 months for the first 2 years, every 6 months until year 5, and then yearly. And it's important, of course, if you diagnose those recurrences or relapses soon and you address them. We do have different alternatives that are emerging now. Because one thing that I forgot to mention that I think is really important is because, I have friends and colleagues all over the world, and they come and say, oh, my patient wants to go to United States or to, another big country next to ours to get the chemo. Okay, chemo is the same all over the world. Like, we have not had any recent meaningful changes in chemo. So the same chemo recipe I showed you guys in the beginning is the same chemo patients will get in Argentina, in Tanzania, in Russia. So there is no reason for patients to travel to get their chemo. There are a few drugs that are emerging now. We're finding that osteosarcomas, as heterogeneous as they are in terms of mutations, they may have some mutations that can be meaningful for to be targeted by immunotherapy, but those are at trial phases right now. We do have a new drug that is called mifepristone. That's only available in few countries in the world. For example, in the United States, not available, but it's a drug that is very good at preventing relapses. So after you're done with your pre-op chemo and your surgery, the drug can be added to the adjuvant regimen, and it has been really good at showing prevention of relapses. But you have to check if that's available in your country or not. So, in conclusion, now you learn the correct definition of osteosarcoma. That is not a tumor of the bone. It's a tumor that produces an abnormal osteoid matrix. Treatment algorithm, same everywhere. The classic one, chemo, with the same drugs all over the world, surgery, chemo. We have multiple surgical options for these patients, and there are many things that may be available for you. Not everybody needs an implant. There are other ways, autograft, allograft, rotation plasty. So you have to see what's available to you and what can help your patient better. And luckily for all these patients, we do have options, and amputations are very, very, very rare. Little has changed over time. We have the same survival rates from 70 years ago, but research still goes on and we have high hopes for the future. So we should continue to watch this. There may be any like groundbreaking research findings soon. So we'll have to keep an eye on that. And so with this, I would like to thank you all for your time and attention. And I hope that this lecture was useful and you learned something today. Thank you so much.